Neuro punishes you harder than any other subject for memorizing without understanding. One changed detail in a vignette and everything you memorized falls apart. Neuro isn't asking what disease this is, it's asking where the damage is. And if you can't trace the pathway from lesion to symptom, you're just guessing and you're gonna lose points on your test. In part 2 of our Neuro series, I'm revealing more exclusive footage from our paid course showing how 260+ scores think through Neuro, how they map the pathway, know where it crosses, and predict exactly what the symptoms should be so that you can get a higher score on this critical subject.
All right, so as a continuation of what it is that we were doing last time, I want to tie everything together, right? So just to, again, if you can put together Brown-Sequard, you can pretty much understand where all the tracts are and where they decussate. If you can sort of understand the deficits that you get with hemisection of the spinal cord. So who wants to give it a try? So Brown-Sequard again is this hemisection of the spinal cord. So who wants to give it a try to put together what would happen to the big four, the little three involuntary movement if I were to hemisect the spinal cord? Which side would I have loss of which? I will call on someone, but Patricia, you want to give it a shot?
Yes. And you lost the big four, ipsilaterally. You lost the little three contralaterally and voluntary movement contralaterally.
Okay, so why? So the key is like, can you explain why that is? So big
Yes.
four, you said what side would you lose it on?
Yes, because big four has no decussation in this area. Little three has decussation in the anterior commissure and voluntary movement is corticospinal tract, and decussation is in the brain area. I don't remember what the area is. Sorry.
Basically in
goodness.
like the inferior medulla.
Yes.
Okay, so because of that, so what side would you lose voluntary movement then?
Contralaterally.
Contralateral. Okay, and tell me why that is.
Yes, because the decussation is in the brainstem. No, sorry.
It's okay.
I don't know.
Can someone help? So this is hard. So David, you said that the decussation happens in the medulla. So what? So what's the clinical correlate then for Brown-Sequard?
If you find this helpful, be sure to check out our 14-step course below in the description. It's completely free and it can help you skyrocket your scores in 14 steps or less. Be sure to check it out.
So if I hemisected my left spinal cord, which side would I lose voluntary movement, David, and why?
Okay, so can you repeat the side again? I'm sorry.
So if I cut my left side of my spinal cord, the left
Yeah.
side of the spinal cord.
Okay, so since you cut the left side of your spinal cord, and since motor, the way I think of it is you're sending it from the brain down to the extremities, whichever one you want to move. So since it already crossed, it's gonna be on the ipsilateral side.
Okay, what do you mean? Since it's already crossed. So what does that mean? Can you explain
Okay,
that a
I'm
little
sorry.
bit more?
Yeah. So since it already decussated, so since it's going down from the brain, and it's gonna cross over the inferior part of the medulla and then innervate. It's gonna eventually innervate the opposite side, but since you already did that decussation and you already made that crossing point, it's gonna affect that side.
Yeah.
I don't know if that makes
Yeah,
sense.
right. So again, there's ipsilateral loss of big four and involuntary movements in contralateral of little three. The reason is, so I think we can all sort of understand why for the big four, why it's ipsilateral, right? So we have the right, in this case, let's call this the left side. So let's say this is the left side. So the left-sided information here is still on the left side at the time that it's cut. Right? So when I'm cutting the spinal cord, I'm cutting the left side's big four. For little three, it's the opposite. It's an ascending tract. And so it decussates almost immediately upon entering the spinal cord. So the right-sided information is actually now on the left side. So when I cut the left side, I'm actually cutting the right side's information. Okay, so that's big 4 and little 3. I think the one that's most confusing is voluntary movement, and that's because it does decussate, but because it's a descending tract, the left-sided information in this case, right? So the left-sided information after it's decussated, right? So it starts on the right in the right brain, but the right brain is controlling the left side of the body. So after it decussates, now the left side is actually controlling the left side of the body. So in other words, the corticospinal tract on the left side controls the left side of the body. So if I cut the corticospinal tract here in the spinal cord, it actually is going to cause ipsilateral loss. This I found very confusing. Does someone, I don't think I did a great job of explaining it. So can someone sort of give me a chance to redeem myself?
I'm not sure if it's a good way to look at it from a sort of like a different way, but maybe you can tell me if this is correct or not. Okay, so I look at where you have the hemisection, and then I compare that to where the tract is exiting, because where it sort of exits out of the spinal cord is where it's going to innervate that, section of the body. So for like the little 3, I look at how it's exiting on the opposite side of where the cord is cut, whereas for big 4 and unconscious proprioception, it's on the same side, and those are ipsilateral.
Oh, interesting. That's very clever. That actually, I think that would work. Honest, that actually works. That's actually a lot more. So did everyone understand that? Because it's very clever and actually much more simple. I mean, you kind of have to have this picture here in order to like make sense of it, but at least right now you can make sense of that. So try it. Can you explain that again?
Yeah. So like I actually like draw a circle in my mind around where the hemisection is, and then a circle around my mind, or in my mind around where it exits out. And then if you compare the 2 circles, if it's on the same side, then it's ipsilateral. If it's on the opposite side, it's contralateral. And it intuitively makes sense to me because you're thinking about what the effect of the cut is. And the only way you can visualize the effect is to see, like on a person, what like motor or sensory function is lost.
Yeah, that makes sense. So in other words, so big 4, for example, it's entering the spinal cord. So you're saying like because it enters on the same side as the lesion, then it's going to be ipsilateral. Whereas the little
Right.
3, because it enters on the opposite side of the spinal cord, it's going to be contralateral.
Right.
And the
Because
voluntary movement, because it exits on the same side as the lesion, it'll be ipsilateral. That makes sense, actually. That is actually very clever. Again, I think that this is particularly useful if you can visualize these tracts. So again, you still need to understand the tracts, but I actually find that that's like at the very least, it makes a good way to double check yourself to make sure that you understand sort of what side should lose what. That's great. Thank you.
okay, cool, thanks.
All right. So let's talk about mixed motor findings. So what's the significance of having mixed motor findings? In other words, what if I have like left-sided facial weakness and contralateral body weakness? Josh, do you know what the significance of that would be?
What do you mean by like the significance?
So in other words, where does the lesion have to be located if there's mixed motor findings? What do you know about the location of that lesion?
After that decussates or
After it decussates, so where? So you're talking about it has to be in the spinal cord, it has to be in like the cervical spine, it has to be in the where would it be?
in the cervical spine?
What do you guys think? Above, before the decussation. So Parag says it points to a lesion above the decussation. I see. So Jolan has it. So it actually tells you that it's a lesion in the brainstem. So the reason being that if you hit like the right side of the brainstem, it's possible to hit. At that point, it should cause ipsilateral weakness. but you still haven't decussated. Well, let's talk about why. So Jolan, can you tell us why?
I guess because that's where decussation occurs in the brainstem. So if you have something happening where you know it's like a stroke, or no, I'm sorry, not a stroke, but like a lesion to the brainstem, you know that before the decussation, it's going to be ipsilateral. And then after the decussation, it already crossed over. So then it has to be contralateral too, whatever happened in the face.
Essentially, yeah. So I guess that the way to think about it is that there's decussations that occur at different points. So the decussation occurs at the level of basically at the level of the brainstem for the corticobulbar tract. And so if you had, say, like right-sided brainstem lesion, you would have loss of the right side of the motor. It would be ipsilateral. It would be ipsilateral motor loss. All right. But because the decussation for the spinal cord happens basically at the inferior part of the brainstem, where the medulla joins with the spinal cord, that hasn't decussated yet. So if I hit the motor tract for the corticobulbar tract, which is the motor for the face, then how would I say this? I would have ipsilateral loss for the face, but I would have contralateral loss for the body. Does that make sense? This is the whole side of the face. And it would be the whole side of the face as well, probably. Although that's not necessarily true. If you hit the facial nucleus, then yes, that would be true. But if you hit the corticospinal fibers that are going to the face, I don't actually think that it would affect the whole face. Don't think so. Again, it depends on if you hit the. We'll talk about the motor findings, the upper versus motor face, or upper versus lower part of the face for motor in a sec. But does this make sense? So the take home that you guys must remember is that if you have right-sided facial weakness and there's left-sided body weakness, the only place that could possibly be is in the brainstem. Why is that useful? That's useful because if you find this, you know that it cannot be one of the major cerebral arteries. Right. So they're going to give you a long, like often for these stroke questions, they're going to give you long lists of different possibilities. And so they'll say like left anterior cerebral artery, right anterior cerebral artery, left middle cerebral artery, right middle cerebral artery, left posterior, right? They're going to give you tons. You know that it can't be cortical. So you can automatically eliminate anterior cerebral artery, middle cerebral artery, and posterior cerebral artery. You know that it can't be there. You also know that it can't be at the level of the spinal cord, right? And so it really helps because then you know that it has to be some sort of artery that goes to the brainstem. So it's very, very useful. Sounds good? Because I think, again, most of us know the anterior, middle, and posterior cerebral artery strokes pretty well. And so the harder ones to recognize are the brainstem strokes. And so if you can automatically, if it's ACA, MCA, or PCA, it's reasonably easy to recognize. If you see mixed motor, then you're like, okay, well, I know that it has to be some sort of blood supply that supplies the brainstem. So this is actually a very useful finding. Okay, so let's talk about this. Parag, I think maybe this will answer your question. So how does this work? Who can walk me through this diagram?
I can try.
Okay, perfect.
Or anyone else.
Yeah, go for it.
So the way I always remember it is a stroke looks similar to Bell's palsy, but a professor was like, a patient came in and said, but look, I can actually wrinkle my forehead. Isn't that good? And then she said, no, that's actually, that's actually worse. And I didn't understand that at the time because that was like my first year during clinical skills. And then when I was studying for this, I realized what she meant. So she said that's actually worse because you have dual innervation to the forehead from both sides. If you look at the picture, to like both sides, you have dual innervation of the upper motor neurons to the lower motor neurons. so that if you were to cut the right side upper motor neurons, you would still have innervation to the forehead because that has a dual innervation from the left side upper motor neuron. But if you cut the lower motor neurons to that left side of the face, you get a complete loss of innervation. So you wouldn't have a facial droop. So we just have complete facial droop with forehead and lower part of the face.
Perfect.
So that,
So the clinical correlate here is that if you have Bell's palsy, you get loss of both forehead and lower face motor function. If you have a stroke, it's really your forehead is spared and your lower face is affected. So let's look at this diagram and understand sort of why that is. So here is the facial nucleus, right? So the facial nucleus gives rise to Mitsu. What cranial nerve does the facial nucleus give rise to? 7, perfect. So it gives rise to cranial nerve 7. And so as Jolan pointed out, there are 2 divisions to the facial nucleus. There is the part that innervates your forehead, and then there's the part that innervates like your lips and the lower part of your face. Okay. So the important part to note is that the forehead part of your facial nucleus is actually innervated bilaterally, meaning that there is innervation both from the right side of the brain and the left side of the brain to the upper part of the face. Whereas for the lower part of the face or the lower part of the facial nucleus, it's only contralaterally innervated. Okay, so what does that mean? What that means is that if I have a stroke, right? So a stroke meaning like a cortical stroke. So let's say that I had an ACA stroke, right? An anterior cerebral artery stroke. If I had an ACA stroke, then I would lose both of these tracts, right? I would lose both of these things going to both the upper and the lower part of the face. However, because there is ipsilateral innervation of the upper part of the face, the only part that I'm actually going to lose is the lower part of the face. In other words, if I try to smile, then I will have a crooked smile. This part of my lips will be upgoing, but this part will not. Does that make sense? Whereas if I have a facial nucleus palsy or a facial nerve palsy, I lose this entire tract, right? I would lose all of this. So I would lose both the upper part and the lower part of my facial nucleus or of my facial nerve. I actually saw this a couple times in the emergency department. Well, sorry, before I tell you a story, what of this does not make sense? Because to be honest, this diagram didn't make sense to me until probably after I graduated medical school. Like I understood I understood what the take home was, but I didn't really understand this diagram. So who doesn't understand this diagram and would like to understand it better?
So one thing I had a question on was the fact that I agree with the idea of whole face versus lower side of the face, but I came across a question one time where there was a lesion, and this is kind of goes to the point you made when I made that comment was, so you can't always assume that it's a cortical stroke, correct? You might sometimes you have to it could be a face, it could be around the pons.
Yeah, I mean it could be anywhere along this tract. Right?
Okay.
Like
Okay.
anywhere, it doesn't have to be a cortical stroke.
Yeah.
You could
Okay.
have like a internal capsule stroke, right?
Mhm.
It could be before the facial nucleus, and that would cause the same symptoms.
Okay.
Does that make sense?
Yeah. Okay.
It's a good question. So it's coming from the right and the left upper motor. So Cher asks, by dual innervation of the forehead, that means it's coming from the right and left upper motor neuron. Yeah, exactly. So in other words, so if we think of the facial nucleus as the lower motor neuron, then the upper motor neuron on the right side and the upper motor neuron on the left side are both feeding into the lower motor neuron for the upper part of the face. Whereas for the lower part of the face, the lower motor neuron, so this is going to sound really complicated. The lower motor neuron for the lower face is only innervated by the upper motor neuron contralaterally. If you followed that, I mean, you deserve a serious prize because I barely understood what I was saying. There's like so many upper and lower and stuff. But yeah, the big picture is that there's bilateral innervation to the upper part of the facial nucleus, the superior portion of the facial nucleus. So this is really important clinically because again, the longer, I mean, it's about 5 minutes that your brain can last without nutrients before you'll get permanent damage, right? It's one of the fastest ischemic times to get permanent damage of any organ that I know. Like the heart is about 30 minutes, but the brain is like 5 minutes. So it's really, really, really fast. So it's really important that you recognize the stroke because not only does time mean brain, but also there is a very limited window in which you can give the treatment for ischemic stroke, which is in most cases TPA, or at least traditionally TPA. So it's very important to recognize this as soon as possible. This happens a lot in emergency departments. So when I was an intern and I was in the emergency department, we had a couple people come in with sudden onset, like facial weakness. You're like, oh my gosh. And I went in and saw them very quickly and basically just had them do this. I would have them sort of smile, and they had an asymmetric smile. And then I'd have them raise their eyebrows and then see like, okay, can they raise both eyebrows symmetrically? And you can actually like try and, push them down, see if like you have to use the same amount of strength on both sides. So in both cases that I saw, they actually they had very clear weakness. One was actually kind of like subtle weakness in the eyebrow, but the other one was very, very clear weakness. In both cases, right? Because again, if it's a stroke, who would I ask? Stephanie, if it was a stroke, if I was worried about a stroke, what would be the next sort of diagnostic test that I would need to do, like stat?
CT to make sure it's not bleeding so you can get TPA to reverse it.
Perfect. And would it be CT with con or without contrast?
And without.
Without. Good. Yeah. Do you know why without?
Why? I think so that you can see the bleed better.
Okay.
But,
Why would you see it bleed better without contrast?
I don't know.
So contrast. So again, this is a little bit of an aside, but I think this is an interesting and important sort of point, is that contrast in this case, when we say like a head CT with contrast, what we mean is IV contrast. So contrast basically is injecting something that's radiodense into the bloodstream, and then it's carried by the blood to different areas of the body. For most things, for CT scans, you would give IV contrast if you could, mainly because you have this, it's basically like this radiopaque dye that just highlights all of the important structures, right? So think about it. You're giving something that's like, it's something that shows up as bright on a CT scanner. And so you're giving it, and so everywhere where there's arterial flow, you will see this bright dye. And so you can just see everything much more clearly. However, the way that you detect blood, again, the whole basis of an X-ray is that something that is radio opaque is electrically dense. So let me say that again. So something that is electrically dense, right? So something like, so anything that's higher up on the periodic table. So calcium is electron dense. So X-rays don't move through it. So that's why on a chest X-ray, that's why bone looks very white, right? Because the X-rays aren't passing through the bone because the bone is full of calcium. Okay. So in the same way, blood shows up because it's got iron in it. Blood shows up as radio opaque, meaning the X-rays don't go through it because iron is dense. So in the same way that contrast works by giving more radiodense stuff to sort of highlight important things, it actually obscures bleeding because the way that you see bleeding is from radiodense areas on a CT scan. So that's sort of an aside. But it is really important to know when someone comes in with a stroke, what you'd have to do is you'd have to do a stat non-con CT of the head in order to see if there's bleeding. If there's bleeding, obviously you wouldn't want to give TPA, which is would just make the bleeding worse. Okay, so in both of these cases, so what would you do? So Parag, so someone comes in, this was like my second month of intern year, or maybe third month of intern year. It was very early on, is when I did emergency department. So it's like your first month of intern year. Someone comes in, they said, doc, an hour ago, I just noticed I had this sudden weakness in my face, and like I smile and it looks funny. You go to them and you ask them to raise their eyebrow, and they are able to raise both eyebrows and it's symmetric. What's your next step? What are you going to do?
I would say hand squeeze, but that's, I think, part of stroke protocol.
Okay. Okay.
But I don't think that's what's.
So what do you think is going on? Because again, right, like time is brain, right?
Right.
If this is a stroke and you miss it, right, that's a pretty sizable lawsuit, probably.
Yeah.
Even though you're an
So yeah, so definitely then go through stroke protocol, check hand squeeze, check hand levels. Yeah, ask them to smile.
Okay, so they
Well,
smile, and there is very clear facial droop on the left,
and their eyebrows are able to raise on both sides.
and they can raise their eyebrows on both sides symmetrically.
Oh yes, yeah, like Bridget said, check the strength of the eyebrows.
Okay, so the strength is the same on both sides.
So
what do you do?
Wouldn't you do the same thing? Non-contrast CT?
Yeah, exactly. So because what are you worried about?
A lower motor neuron lesion. Or another.
Really? Wait, why am I lower motor? But what would you be looking for if you were worried about a lower motor neuron lesion? Like, what would you be working for with a CT?
A stroke.
Okay, so why are you worried about a lower motor neuron lesion?
Would it not be a lower motor neuron lesion, like, in that same area?
Oh, no, it'd probably be a cortical stroke, right? The most common strokes are like MCA or maybe like common carotid.
Okay.
Or internal carotid, common carotid. So it'd be like you'd be worried about it like an MCA stroke. Okay, so so again, if you're worried about a stroke, it is a non-con stat head CT.
Okay.
Right? It's kind of scary, right? I mean, but this literally, there's going to be a point in time in which you will have to make, like, as an intern, I was like, geez, man, this is like really scary. If I like just kind of sit here and don't do anything, this guy might have
Die.
permanent damage. Well, I mean, so strokes usually don't cause death, but they're the number one cause of morbidity in the United States. Right. So, I mean, I honestly think that would be in some ways worse, right? I don't know what would be worse, like just dying immediately or just like living for the rest of my life like hemiplegic. I don't know. That'd be pretty bad too. So, yeah. So that would be okay. So Patricia, so what kind of
Alec.
presentation would I not worry about? So what would be reassuring about if someone were to come in and say, "Oh my God, I just have some like a sudden onset facial drooping."
If I had only lower face division paralysis, I can think about viral diseases or idiopathic in the lower motor neuron only. If I had in forehead paralysis, think about stroke in both hemispheres and probably MCA, and I have to perform CT without contrast.
Yeah.
Yes.
Yeah. Exactly.
So I have a question.
Sure.
If I have forehead paralysis, I have to think about stroke in both hemispheres.
Oh, I mean, that would be pretty obvious because if that were true, if you had like a really wide area stroke, then you'd also have like other signs of like weakness on. So you're saying, what if would it be possible to have a bilateral stroke that caused both like weakness in both like the upper and lower forehead? I mean, I guess it's possible. I mean, it'd be highly like probabilistically very unlikely that you'd have a stroke at the exact same time and in like symmetric distributions, that'd be very, very unlikely. The other thing is that if that were true, then you would expect bilateral weakness, right? So it would look very different. They wouldn't have like they would have like, I mean, I guess it would be probably a symmetric smile, but they wouldn't be able to smile, period. Like they wouldn't be able to move their face.
Okay.
Does that make sense?
Thank you. Okay, absolutely. Thank you.
I had just kind of dawned on me. Would you check Tchaikovsky's sign, or is that only for hypocalcemia?
Svastic sign?
Yeah, sorry.
No, yeah, that's because that's for hyper reactivity. So no.
Okay.
Yeah. I mean, the honest truth is that like, I mean, as soon as someone presents with this, like you probably wouldn't check anything else. You would probably just send them immediately to the scanner. Right? Because again, I mean, most hospitals are, or like stroke centers are basically judged by time to presentation to time getting a scan. So anything that you do that delays the time, like how long it takes for them to go to the scanner is potentially harming the patient, and B, going to reflect poorly in your presentation. I forget what they call it. I think it's like door to scanner time. I think is what they call it. It's like they have similar metrics for like door to cath times. Like when you come in and they think you've got an MRI, like how long does it take you to get to like? So they have these like 24/7 stroke pagers where, if someone's coming in with what's concerning to be a stroke, they have this specialized stroke team, usually I presume like a stroke fellow and maybe like a neuro resident and like an attending or something at least at like MGH, where they come down, will immediately evaluate the patient as soon as they get there and then triage them to say like, do they need to go to the scanner or not? So a lot of these tertiary centers like MGH have stuff like that. Stanford had that. Stanford was a stroke center. Okay, so this is cool. All right. So to make sure that we all understand. So Marlene, so if someone comes in with a facial droop, is it more concerning if they can move their forehead or less concerning?
I think it should be more concerned.
If they can move their forehead, yeah. It's more concerning if they can move their forehead. Yeah, exactly. Perfect. Okay, so let's switch gears and let's talk about upper motor neuron and lower motor neuron findings. This is like everyone's favorite subject. So Sharon, can you tell me if you have spasticity, is that an upper motor neuron finding, a lower motor neuron finding, or both?
It's a upper motor neuron
Upper
finding.
motor neuron. Perfect. Yeah. And so Cher, weakness, is that upper or lower motor neuron?
So weakness is, I think that's lower motor neuron.
Oh, interesting. So it's actually non-specific. It's actually both.
Oh,
right?
okay.
If you have right? Think about it, right? If you have a stroke, like a cortical stroke, infused stroke, you're weak, right?
Yeah.
But if I have like a spinal cord injury and I hit the anterior horn, you're also weak. Right?
Oh, sure.
So weakness is non-specific. How about Jolan? Atrophy. What do you think? Upper, lower, or both?
I think it's lower.
Why would that make sense? Why would it make? Because again, it's. Why would that make sense that it'd be lower? You're right, but why?
Well, the muscle is going to be directly innervated by the lower motor neuron. So if there's something wrong with the lower motor neuron, then even if the upper motor neuron was working, it wouldn't be able to send the connection all the way to the muscle.
Yeah, I think the easiest way to think about this is that the lower motor neuron stimulates the muscle, right? Regardless of if there is upper motor neuron input or not, it's still going to innervate that muscle. And so there is it's a fancy word, but they say it's like a neurotrophic effect. So in other words, they're trophic meaning like growth. So if I lose the innervation to a muscle, I'm losing that stimulation. I'm losing sort of the growth effect of that. Does that make sense?
Yeah, I was just thinking about when you said neurotrophic, does that have to do with like BDNF or like protein synthesis?
Oh, I don't know actually. What is VDNF?
It's like brain-derived neurotrophic factor.
I don't know. Honestly, don't know.
Okay.
David saying upper motor neuron can be disuse atrophy. Yeah, I think like eventually that's probably true. But I think like I think in general atrophy is, so yes, if you don't use your muscle at all, then you will suffer atrophy, sort of like if you put your muscle in a cast. But I think a more profound atrophy happens from losing the innervation in the first place. How about fasciculations? This is a really common one that you'll see. So let's go with Josh. So fasciculations, is that more upper or lower motor neuron?
Lower?
Lower. Can you explain the pathophysiology of why that might be?
I'm not sure.
Does anyone know? This is actually really interesting and comes up not infrequently on USMLE. No one?
I thought it would be upper.
No, it is lower.
It is lower.
Yeah. Stephanie, do you have an explanation for why that is?
No, I thought it was like it's lower because the upper neurons, someone explained it, like they kind of go a little bit crazy and then you get these like kind of spastic idea, but I don't know.
I don't think that's true, actually. So that does explain spasticity. I think that is true. When you have, that is an upper motor neuron finding. Fasciculations actually happens. So if you think about each nerve gives off some sort of, like if you think of like a motor unit, right? A motor unit is where you have a nerve branch that goes to a grouping of muscles, right? So maybe that motor unit is like one small group of muscles, and then another motor unit is another small group of muscles. If I have a lesion in a lower motor neuron, what ends up happening is my motor units end up getting larger. So in other words, one sort of branch of a nerve ends up innervating more muscle fibers. As a separate phenomenon, there is sort of spontaneous depolarizations of the nerve fibers to the muscles. So in other words, there is, like, you can't see it. For most people, if you sit there, you could watch yourself for hours and you wouldn't really see any fasciculations, because there is spontaneous firing of the muscles, but because the motor units are so small, it's imperceptible with human vision. However, when you have reinnervation, right? So in other words, when I have a lower motor neuron deficit and I have adjacent lower motor neurons that then will take over to innervate the previously deinnervated muscle fibers, the motor unit actually gets larger. So when that motor unit will spontaneously depolarize, it actually will be visible to the human eye. Does that make sense? So there's always spontaneous depolarization of motor units. However, when the motor units are small, you can't see it. When there is regrowth of nerves such that there is larger motor units, then you can actually see the fasciculations. You can see that spontaneous depolarization of the motor units. Does that make sense?
Alec, I have a question.
Sure.
I think about the capacity of the peripheral nervous system to regenerate axon through the Schwann cells, yes? And creating grow of cones. This grow of cones can cause irregular depolarization, causing fasciculation, no?
So I don't know. I don't think it's a growth phenomenon. I don't think that it's because of the regrowth. See, what you said is true, but I think it's unrelated. So, or at least unrelated to the depolarization. So it is true that you can get regrowth of the peripheral nerve fibers. It is not true, though, that I don't think it's true that the regrowth of those peripheral nerve fibers leads to spontaneous depolarization. My understanding is that you always have spontaneous depolarization. You just are able to see it in the case of lower motor neuron damage because you have larger motor units. But you have larger motor units because you had that regrowth in the first place.
Yes.
Does that make sense?
Okay. Yeah, of course. Thank you.
Other questions about this? Because this is, of all of the signs, honestly, this is probably the most important because it shows up. I would say this and like hyperreflexia show up the most in terms of things that you're most likely to see in a question stem. So it's really important that you understand. Plus, this is the one where they'll actually ask you about the pathophysiology in your exams. So I either explained it well enough that you guys followed, or I explained it so poorly that you just don't even know where to start. It's going to be one of those two.
Alec,
What's up?
I have a quick question. I'm sorry. So it was a good explanation. But if you have neuronal cell death, I thought another reason why this happened was because
Because what?
you can get released periodically or in the
Oh, you just
beginning.
cut out. Say that again.
Sorry.
You're cutting out a lot. I'm not sure if you're speaking or you can maybe type it. That might help. I'll move on to hyperreflexia, and then I'll deal with your question once I can see what you type. Let's do Josh. So Josh, hyperreflexia, is that an upper or lower motor neuron finding?
I think upper.
Upper. Yeah, exactly. So David asks, as you have neuronal cell death, those neurotransmitters can get released and cause these fasciculations. I don't think that's true, right? Because the reason why I don't think that's true is maybe there is some component of neuronal cell death causing release of neurotransmitters. The reason why I don't think that's true, though, is that you see this phenomenon happening long after. You can see it happen long after, like, the injury. So that can't be the only reason. Right, you can still see fasciculations if they have, like an injury that was like a long time ago, and there's not active death of the lower motor neuron. Perfect. All right. So there's a couple other clinical pearls that I think are important for you guys to know that I want to discuss. So what's a good way? Again, this is sort of like a read my mind question, but share. Who would I suspect MS in? Like, what's sort of like a good way to think of MS in terms of like lesions or tracts?
Oh, I was just thinking like in terms of like this, so they have deficits in it's like where it's the space and time. It's not. It doesn't seem to be one area. It seems to be multiple areas involved. Like
Perfect.
those. Yeah.
Yeah, exactly. So if I can sort of refine that a little bit, I would say it's neurological deficits that can't be explained by a single lesion. Is that a fair sort of representation of what you said?
Yes. Exactly.
So in other words, if you get a distribution that looks like the MCA, I mean, I guess it could in theory be MS, but it's probably not, right? But if you get like this weird sort of patchy thing where like they've got one side of their face is weak and the other side of their body has loss of sensation, but there's no problems with strength, and they've got like weird eye finding, that would be MS, right? Like if you can't possibly explain all of the different things by talking about a single lesion, then you should be thinking MS. Stephanie, what makes MS worse, and why might that be?
It's heat because it causes the neurons to have poor conduction. So things get worse.
Yeah, exactly. And honestly, I don't really understand why heat would cause worse conduction. Normally, you think of heat as like increasing the rate of sort of chemical reaction. So it's kind of odd to me. The way to tie this in with the pathophysiology is that, again, what's the problem, Parag? What's the problem pathophysiologically with MS?
So you have destruction of the white matter, your oligodendrocytes with MS, and that's going to end up causing kind of like a recalculation in the time that it takes for a neuron for the signal to travel from one end of the neuron to the other end.
Why would that make sense? Why would problems with your white matter cause an increase in signaling time?
Because it ends up messing with like your spacing of the nodes.
So in other words, so you're saying that
Is that too
myelin is important for the speed of conduction, speeding up the rate of conduction, and that with myelin you have these things called the nodes of Ranvier, and that if I lose oligodendrocytes and I lose my myelin, then I would have disruption of the transmission. Is that what you're saying?
Yes. Yeah.
Perfect. Yeah, exactly. And so if I slow that down even more with exposure to heat, then it would make sense then that my symptoms would be worse.
Mm-hmm.
Cool. Awesome. Perfect. What, Bridget, what would be the location of a stroke with pure motor findings? Where would it have to be so that it only affected the motor tracts and didn't affect any sensory tracts?
Just the motor tract. Probably in the motor cortex.
Motor cortex. So I guess that's true. I mean, so what kind of stroke would that have to be?
Not a good one.
Okay, fair. But I mean, like, what kind? Are we talking like an MCA stroke? Or are we talking like what kind of stroke would that have to be?
I would say probably, I think it's MCA, or it depends on location. If it's a lower limb, isn't that ACA?
Yes, that's true. However, don't ACA and MCA also give you sensory deficits?
They do.
So it wouldn't be a pure motor stroke, right? Can someone help? What would give us a pure motor stroke? So this sometimes comes up. So it actually is the internal capsule, right? So the internal capsule, if you hit at least part of the internal capsule, the part that is I actually think it is just motor. At least if you hit the part of it that's just motor, you can get a stroke with pure motor findings. How about a stroke with pure sensory findings? Where might that be? Sharon.
I think not
These are hard.
exactly.
These are sort of use my mind questions. The
Yeah,
thalamus.
I was thinking the thalamus. I just didn't.
It's okay. So yeah, so a thalamic stroke can give you pure sensory findings. Okay, so now so before we move forward to doing more clinical vignettes and looking at spinal cord lesions, what questions do you guys have before we move on? Nothing. If someone comes in and they've got like an asymmetric smile, you guys all know what you're supposed to do. You guys know what you're supposed to do after that, depending on what you find. I hope so. It's actually not that complicated, but you just have to remember non-contrast CT. If they can't move, if their eyebrows are spared, we would do a non-con CT. Perfect. Okay, Jolan, what's the diagnosis here? First of all, tell me what is being affected, and then tell me what you know that could cause this particular distribution of findings.
That is your dorsal columns, your DCMLs. So that would affect PVT, proprioception, vibration, fine touch, the big four. And I don't know why it is, but I know you see it in syphilis. So it would be an infectious cause. And with syphilis, I think you get the neuro findings a lot later. So it'd be like the very latest stage, like
Yeah. So primary, secondary, or tertiary syphilis?
Tertiary, probably.
Very good. Yeah, exactly. Yeah. So impaired conscious proprioception, right? So they call this tabes dorsalis. Tabes, I actually don't know why it's called tabes. Dorsalis because it's the dorsal columns. This is actually there. So someone explained to me once that the reason, like they used to call it, or maybe you still call it this, a Tibetic gait. So like someone that has like tabes dorsalis, they have a very specific gait. And what they do is they'll lift their feet very high up into the air and sort of slam them down into the ground. And the reason for why it's thought that that's true is that they have lost their proprioception. So they don't actually know where their feet are in space. And so they have to rely on other things like, vibration technically is still part of it, but I think you lose vibration later. But like vibration, or even like some crude touch and pain, where they have to rely on sort of slamming their feet on the ground in order to feel where their feet are in order to walk semi-properly. Isn't that cool? All right. I already gave the answer. Josh, do you know what other disease can give you problems with the dorsal columns, or like specifically with the dorsal columns?
I'm not sure.
So the Friedreich's ataxia also gives destruction of the dorsal columns. Harag says tabes means emaciation. Oh, interesting. So they're emaciated and they have problems with their dorsal columns. Or maybe it means that the dorsal columns are emaciated. I don't know. That's interesting. I didn't know that. Mitsu, what disease is this?
Syringomyelia.
Okay. So what findings would we expect and why?
It's both sensory loss.
It's both what?
Both side of sensory loss.
Both side what loss?
Both side of I said sensory loss.
Sensory loss. Okay. Well, what sensory loss? Big 4, little 3. Well, what?
Little three.
Little 3. Perfect. And why? Why would you lose bilateral little 3?
Because from the both side, it's as from the posterior form, sensory input is coming in from the both side, and it's crossed at the center. So when the region is at the center, the both input is how to say disturbed. That's why.
Yeah, perfect. So in other words, so I think what Mitsu's saying is that you have the anterolateral system enters in here, right? And then it crosses in the anterior white commissure, which is right here, and then goes basically here and ascends. But it crosses right in front of the spinal canal. So if the spinal canal is then enlarged, what can happen is that you'll get compression of the anterolateral system on both sides. Yeah, perfect. David, what's sort of the classic description of syringomyelia and why? Like in terms of the sensory loss.
Cape-like loss of sensation, I guess, is what I've heard.
Yeah, and why? Why is it cape-like? Like why does that make sense?
Why does that make sense? We're trying. What do you mean? Like, why is it that kind of distribution? Yeah. Well, isn't it just because of the what's the word? The where the lesion is most common. I think it's lower cervical.
Yeah, exactly.
Lower cervical region. So that's kind of the reason why I think that would be the case.
Yeah, exactly. So if you think, so it affects, in other words, it affects the upper extremities much more frequently. And if you think about it, the reason why is not because there's anything special about the upper extremities, but because syringomyelia tends to happen more in the cervical spine. It happens much more frequently in the cervical spine. So yeah, perfect. And the cervical spine meaning like it would affect the upper extremities. Bridget, you had a question?
Do you by chance know why it is the cervical spine, in particular, like why it likes that location, or is it just?
That's a good question. My guess is it's like a pressure thing, because oftentimes it'll happen from. That's a good question. I assume because it's often associated with like hydrocephalus, so I assume it's like a pressure thing. So
Also, Alec, I'm sorry. Also, isn't it also?
Oh, I'm losing your audio.
Isn't it also associated with Chiari malformations as well?
Yeah. So I don't know. I assume that it's because the pressure in the cord is highest. It's highest like proximally. So if you think about like, this is sort of how I always justified it myself, that if you have like a backup of something, the pressure most proximal to that backup is going to be highest. So if I was going to have an enlargement of my spinal canal, the blockage happens at the level of like the brainstem, like early cervical spine. And so anything that is just proximal to that would be more likely to be affected. That would be my guess, but I don't know for certain. It can also cause motor findings. So why and under what circumstances would it cause motor findings, Stephanie?
It cause motor findings just depending when the voluntary tract comes down, and
so what does it affect?
innervates it.
And so that like what would it affect in order to hit the motor traction? Would it be an upper or lower motor issue?
Lower motor neuron of
Okay.
the
So what would it
voluntary
affect?
tract. It would affect the
So it's the anterior horn, right? So
Oh,
the
okay.
anterior horn, right? So this is always confusing because it has to do with the way that they stain these sections. But these are actually the gray matter, and this is actually the white matter. All this black stuff is actually in these slides is actually white matter, even though it looks gray, and all of the stuff that looks white is actually gray matter. It just has to do with the way that they've seen it. So the anterior horn is where the lower motor neurons sit. And so the idea is that if this enlarges enough, then it will cause compression of the anterior horn as well. Cool. All right. How about Bridget? What about this? What is this? What would you expect this to be? First, tell us what the distribution is, and then tell us what disease process this might be.
So the disease process itself, I don't know off the top of my head, but just by looking at it, I see that an anterior horn is knocked out. So that would be ipsi or the same ipsilateral motor movement would be out on that side. And then when I look towards, let's say, the posterior, it looks like part of the dorsal column is out. Specifically, I think that's the cuneatus would be running around there. So I think that would be upper limb. So I would say upper. Oh, and it also based on that, it would be on the same side. So I am totally blanking on which is right or left right now, but it would be same side motor movement of where the anterior horn is knocked out. Then same side big 4 would be knocked out, pressure, vibration, fine touch, and proprioception in the upper limb on the same side.
Okay, perfect. Who can tell me what the disease process is? Or can anyone? Who would give us this kind of distribution? Yeah, probably MS, right? So again, remember how we were saying that there is like, if you can't really explain it with one particular lesion or with one particular distribution that's like known, then you should be thinking more MS, right? Just like random sort of collections of deinnervation makes sense that it'd be MS. Okay, so how about this one? This one's a challenge. So Parag, can you walk me through, first of all, what's being affected here, and what disease might that be?
Ooh. Okay. So I want to say it's ALS maybe, because you're losing. So the two you're losing on the sides is going to be motor.
And what does that represent though? So motor, like what motor? Like upper motor neuron, lower neuron?
Lower motor. I think it would be lower motor. No. Oh no. No. Wait. Would it be both? No. Yeah. Lower motor.
Which? The stuff. This stuff right here. This one. This one.
Yeah.
Okay.
Yeah. The two on the top would be lower motor neurons. The two inside the dorsal horns, I'm not sure of.
You mean anterior horns, ventral horns?
Sorry, yeah, anterior horns, ventral horns. Yeah. Yeah, I'm not.
David,
sure
walk us through. So David says that they're upper for the side. So why is that?
So basically, my thought process was the sides are gonna basically pick up info from the brain. So that's that connection. And then the anterior horn cells are gonna be the ones that kind of take it out to the periphery, if that made any sense.
Only if I knew what you were saying beforehand. So Jolan. Well, okay, go ahead, David.
Okay, sorry. So the sides, if I remember correctly, the sides are the lateral cortical I think the lateral cortical-spinal tracts, and then the other ones are the anterior horn cells. So it's basically you're going from the brain to the lateral cortical-spinal tracts, and then so that's considered upper motor neuron. And then your anterior horn cells out are going to be the lower motor neurons. That wasn't really great explanation, I guess, but
that's pretty good. So in other words, the anterior horn, remember, the anterior horn is the lower motor neuron. This is where the lower motor neuron sits. The lateral corticospinal tract, which, as David points out, is basically the axons for the upper motor neuron, which is sitting in the motor cortex, right? So if you look at if you actually think about this picture, these tracts right here are actually going to the inferior, how do I say this? they are going to innervate the anterior horns inferiorly, right? These are going, like, they're most likely not going to this anterior horn, but it's going to go to some part of the spinal cord that's inferior. Does that make sense? So yeah, so this would be ALS. And the reason that you know that is because there's both upper motor neuron and lower motor neuron affected. Note that there's no sensory deficits, right? There's no problem with dorsal columns. There's no problem with the anterolateral system, right? It is just motor. So it is just upper and lower motor neuron. So that, again, is amyotrophic lateral sclerosis. Good. All right. So how about this? Let's go with Sharon.
1 second. So I think so they're showing the anterior horn cells are affected, so it's lower motor neuron lesion, I think.
Mhm.
And so I think it's indicating if it's just lower it's probably polio.
It's probably what?
Poliomyelitis.
Polio. Great. Yeah. There's like maybe one or two other diseases that this could be. Can you think of what they might be? So polio is definitely one of them.
I think there's this Werdnig-Hoffman disease.
Very good.
I'm
yeah,
not
exactly.
it's randomly remembered, but
Yeah,
I don't
like
think
I've
I
never seen it
understand
in my life, but yeah.
Yeah,
Yeah.
it's
okay.
very just
Yeah, perfect. So polio and Werdnig-Hoffman disease both can affect, again, lower motor neuron only. Again,
Mhm.
so how, how might that present if it was lower motor neuron only?
So I think it would be only like motor deficits, and with polio they get like the paralysis of their extremities. Usually.
Uh-huh. So, but again, paralysis just means weakness, right? Which, again, is not specific to any sort of upper or lower motor neuron deficit.
Oh, so
There you go. So David says flaccid paralysis. So what does that mean?
right.
As opposed to what? Cher, what do you think? So if it's flaccid paralysis, as opposed to what? And why would it be flaccid paralysis? Would you even agree that it's flaccid paralysis?
So I guess I'm not actually sure what that indicates versus like another type of paralysis. I'm not sure. Actually.
Yeah, so flaccid paralysis versus like spastic paralysis, as David's pointing out. So David, can you walk us through, like, what's the difference? What does that mean?
Okay, so flaccid paralysis, basically you have a loss of muscle tone, whereas spastic paralysis is you have like severe, like basically the only word I could put it is like hypertonia.
Yeah, exactly. It's sort of like an increase in tone. It goes along with sort of hyperreflexia, but it's sort of a distinct entity. Yeah, but it's basically like I guess it's like a tone thing. I don't know exactly. Yeah, it's just it's just like very limp, as opposed to in the case of spastic paralysis, it's like they'll get like these like contractures. We had a woman in the ICU actually one time where she suffered like it was an internal carotid stroke, so it's huge stroke, but she had just like these really bad contractures. Like her arm was just really 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 stiff. It was weak, but it was very very stiff. So flaccid paralysis happens from lower, and spastic is from upper motor neuron deficits. Yeah. So again, you can sort of put it together with the whole picture of there is increase in tone, increase in reflexes when it's upper motor neuron deficit versus a decrease in tone, a decrease in, so we're getting flaccid paralysis if it's lower motor neuron. Perfect. How about this? So this one's challenging. So Jolan, do you want to give this a shot?
I honestly don't know. I mean, I see multiple tracks. I see like multiple.
So again,
Yeah.
so I think in neuro, I think one of the most important things to do is to define what tracks are being affected. Once you do that, then it becomes more straightforward in terms of figuring out like what's going on.
So DCML is affected.
Okay,
See this
good.
in the back. The sides would be the lateral cortical spinal tract.
Perfect. Good. Okay. So there we go. So now you just have to figure out what disease process can affect both DCML and lateral cortical spinal.
That's so general. Well, you mentioned earlier like Friedrich's, and the only reason I think of that is because it has like the whole thing about it is like ataxia, because like and maybe you can explain this later. I don't understand why for taxon and like loss of that would lead to this finding, but it's like degeneration of many spinal cord tracts.
Yeah, good. Well, so there's Friedreich's ataxia is one of them. So this is called broadly subacute combined degeneration. So the one that you're probably most likely to see is Friedreich's ataxia, but you can also see it in vitamin B12 deficiency. That's probably the other more common ones. So yeah, B12 being a problem with myelination if you've watched my lectures on biochemistry and like the pathways. And then vitamin E deficiency because it's a problem with
Oxidative stress.
yeah, exactly.
Antioxidant.
Vitamin E is an antioxidant. David says this was one of his questions on step 1. Hey, well, actually, what was the actual question, David?
Okay, so it was literally the neuro symptoms were present, except the kicker was that the person had a microcytic anemia instead of a macrocytic anemia. So you'd think that normally with this, you always go with you always want to go with vitamin B12, but since it was a microcytic anemia, it's the more appropriate answer was vitamin E deficiency, just based off of that one kicker. So
That's
I
clever.
guess in my med school, we always learned B12 for this, but if you don't read it carefully, this is it's an easy question. You just have to, if you read it carefully, you'll get it. It was just the difference between the type of anemia.
Yeah, that's very clever. I mean, again, this is why it's funny because like people obsess about like memorizing the details in first aid, but very few questions nowadays are answered by just memorizing details in first aid, or even for that matter, memorizing details from your world, right? So many of the questions have to do with like being able to sort of integrate things. And so, yeah, I mean, there's a number of things that can give you subacute combined degeneration. B12 is certainly one of them, but if they don't have a macrocytic anemia, it's unlikely to be a B12 deficiency. So, yeah, perfect.
Alec,
Yeah, what's up?
for B12, isn't it also like there needs to be something else too? Like you need to either be a vegan or you need to have like, sorry about that. You need to have like intestinal problems too. Because otherwise you don't develop.
You're saying B12, like B12 stores last for years, so it's pretty rare to have a deficiency, and the people that do oftentimes have like either profound malnutrition or they are like vegan or
like droop or something.
they
Yeah.
have like pernicious anemia. Yeah, it's pretty rare. Yeah, but I mean,
Okay.
it's I think also probably pretty rare to have a vitamin E deficiency too, right? So in other words, I wouldn't.
Oh, is it? Okay.
I wouldn't. I think that using epidemiology as a way to eliminate answer choices is not always the best way to do it, right? Like in other words, if you gave me the choice of, okay, they've got a microcytic anemia, they've got no family history of any sort of like ataxia problems, but they have this DCML and corticospinal tract problems and a microcytic anemia, I wouldn't eliminate. I wouldn't choose B12, or I wouldn't I wouldn't eliminate B12 just because it's rare, right? I would have to have something else.
Okay. All right. Cool.
That's where the question interpretation comes in. Epidemiology. I mean, again, I think it's like that's one of the weaker ways of eliminating something. Like by itself is probably not enough, but it may be enough to swing me one way. So how would this, Mitsu? How would this present?
Sure, I'm not sure, but ephemeral vibration, like a fine touch, a big four were, 100 degrees, or just disappeared. And can you hear me?
Yeah. No, that's perfect. I mean, yeah, you don't have to. As long as you understand like the general sorts of deficiencies, it makes sense, right? So why would you be, Mitsu? Why would you be hyperreflexive?
It's because corticospinal tract is affected.
Yeah, exactly. So in other words, the upper motor neuron.
Upper motor neuron, yes.
Yeah, exactly. Okay. All right. So.
But how about this?
Uh-huh.
How about this? Spinocerebellar. It's called ataxia.
Spinocerebellar tract can cause ataxia. Yeah. So spinocerebellar is We didn't talk about this, but it's unconscious proprioception. So yeah,
Oh, okay.
presumably it would also cause ataxia, mainly because you, again, would just like Tavies or Salas would not know where your limbs were in space.
Okay. So that's why it causes ataxia. I don't know.
Oh, you're asking in Friedreich's ataxia, is this why? I think actually you can explain the ataxia just from the fact that you have DCML problem.
Okay.
That'd be my guess.
Okay, thank you.
Just
Thank
because
you
you
so
don't know
much.
where your limbs are. That would be my guess. I don't think you, in other words, I don't think you have to invoke the spinal cerebellar tract in order to explain it.
Okay.
So Cher's asking which part would cause the ataxia. I assume it's this one.
Okay.
Okay, so I have a clinical vignette that I have been like dying to go over with you guys that I made. So let's do that. So Josh, walk me through the first sentence.
A 43-year-old man is brought to the emergency department immediately after finding unconscious and unresponsive at his home. Do you want me to read the whole
Nope.
question?
First sentence.
Oh.
So again, you're trying to frame this and say like, okay, well, what can you get out of the first sentence? So this is probably the hardest. This is the hardest thing to do, is the first sentence. It gets easier once you're able to read other sentences. But just based on the first sentence, what can you get out of this?
That it's a urgent situation that it's not conscious.
Yeah. But you should be thinking about like particular causes that could lead him to this presentation, right? So like what are probably the top 2 or 3 things that this could be?
MI?
Okay, and a 43-year-old guy, maybe, but what would have to happen if this was an MI? So again, the goal is when you give a story, you can't just throw out like maybe this is MI. You have to be able to tell me from the day that he was born to the day of his presentation, like how would this all play together, right? How could an MI lead to unconscious unresponsiveness?
Okay.
So how would that happen? It's possible. So how would it happen?
I mean, I can't think of something that's like would make him unconscious at the top of my head.
Okay.
At the age of 43.
Okay. All right. David, I'm going to pick on you because you are actually in clerkships. So what do you think? When you read this first sentence, what would you be thinking? Like what are the sort of top 3 things that you think this might be?
You might be thinking 43-year-old, you might be thinking like some kind of drug overdose.
Good.
Would be something I would be
that would
thinking
be probably the top on my list, would be like ingestion of something. Yeah. What would be other possibilities?
Besides that, maybe besides ingestion, it's hard to tell. I'm gonna be a little biased because I did read the next sentence with polycystic kidney disease.
Well, let's just do the first sentence. So again,
yeah. So honestly, the only thing I can think of in a 43-year-old who's unconscious, like besides ingestion, I don't know, maybe some type of aneurysm maybe would be something that I would think of. But
so what would have to happen to the aneurysm? Again, so you can say these things, but you have to actually say like, okay, well, if there's an aneurysm, what would happen and how could it cause him to be unconscious?
So if you have hypertension and it's not very well controlled, that could lead to the rupture of the aneurysm and can cause symptoms.
Why? But like, what would the symptoms be and why?
Do
you see? So again, so the reason why I'm pushing you guys is not to be mean, but the reason why I'm pushing you guys is that like, I had a lot of trouble with neuro questions, and the reason why I had a lot of trouble with neuro questions is because I couldn't explain exactly why these symptoms were happening. So I just had like these vague ideas, and I was just hoping for like buzzwords to like come to me. Whereas if you can actually explain why these symptoms happen, it becomes much more clear exactly how you can answer these questions.
Well, okay, so I'll give it a try then based on the aneurysm aspect of it. So if you have a ruptured vessel, and because you have a ruptured vessel, you're not perfusing certain areas of the brain well, that could lead to a state of unconsciousness.
Okay, kind of. I mean, unconsciousness, like, That'd be more like hypotension and like global ischemia. So it'd be a
Uh-huh.
little hard. That'd be a little hard. Jolan, what do you think?
I mean, I think it could be a lot of things that just the first sentence. So usually, like you were saying, if you have low perfusion to the brain, then
So
you could have syncope and
do it. Good.
yeah, hyperperfusion. So things that could cause that would be like severe dehydration, like if someone was running a marathon and didn't drink water or is hot and so I can see somebody like that passing out. It's a 43-year-old man. He could have been an alcoholic, and then he drank too much, and then that could cause loss of consciousness too. He could also have low blood sugar, like he could be diabetic.
So that would be the other
Yeah.
one that I was thinking. So honestly, so hypoglycemia, some sort of drug overdose, or some sort of like hypertension or some like a ruptured aneurysm would potentially make sense, but maybe not for the reason that David was saying. Okay, so Bridget, walk me through the next sentence. So how does this change your differential? What kind of story could you build based on this?
Do you want me to read the sentence?
Yep.
He has a long-standing history of polycystic kidney disease and has had several mini strokes recently. Review of his medical history reveals 2 prior hospitalizations for lacunar infarcts with minimal residual deficit. So I'm trying to go back to the lacunar infarcts, and I believe when I think back to those, they're due to hypertension, uncontrolled hypertension. So that's what I start to think about. These mini strokes would be of concern, but in part from that, I would not be able to deduce anything.
Okay, so I'm going to push you. Okay, so you did the normal thing, which is you said, okay, well, lacunar infarcts, I'm thinking uncontrolled hypertension. It's sort of like the buzzword approach to medicine, which is what most people do. I'm going to push you and I'm going to say, okay, so if you think that there's uncontrolled hypertension, again, consider the context. What do you think? So how does that change what it is that you were thinking based on the first sentence?
So, well, okay. So to answer your question, how that it would probably lead me more towards some sort of rupture, right? Be back towards like aneurysm.
Okay.
But then when I look at like polycystic kidney disease, then I start to think more of like circle of Willis aneurysm, or I think if I'm remembering correctly, polycystic kidney disease also is associated with I almost said little blurbs, but little aneurysms in the brain as well.
And why? So again, the goal is I mean, like honestly, at this stage, you guys probably have enough information to answer this question. You could probably, if I just gave you the question, you could probably you have enough information that you could probably answer it. Maybe it's questionable, but there's a chance that you might be able to answer it. But what I'm pushing all of you guys to do is to make what I call pathophysiological chronologies, right? From the date that this person was born to the day of his presentation, you need to tell me exactly every step of the way, how did he get to become unconscious and unresponsive? So give it a shot, Bridget.
So, well, okay.
And everyone else think about your answer because I'm going to call on you next. So you're not
Okay, so let's say I have 2 different routes. So polycystic kidney disease, and then I have lacunar infarct. So I'll go with lacunar infarct. So I'm a little bit more comfortable with that. So let's say he has uncontrolled hypertension, and what is hypertension? Hypertension is high blood pressure in arteries, and so then that can push on the artery walls, damaging the artery walls, leading to atherosclerosis and so on and so on. And so that can damage. Usually it tends to show up more, I believe, in the smaller arteries first. So you can see that in the kidneys, but it wouldn't show up as polycystic kidney disease. So then if I go back to polycystic kidney disease, then if I go back to polycystic kidney disease, as David mentioned, he said it's a genetic defect that causes an aneurysm, but I can't remember the pathophysiology of polycystic kidney disease. All I do remember is there's like an association with it. But if I kind of think about why are there cysts developing, I'm thinking of, let's say there's some sort of weakness between structural walls. So whatever makes up the walls of, let's say, blood vessels, or let's say the kidney interstitium is weak. And so if there's weakness in those walls, then that can lead to the dilation of that structure. And so therefore, it's now also translating to weakness in structures in the brain, specifically these blood vessel structures.
Okay. So again, how does this, but again, the question is, how does this relate to the presentation? So Stephanie, so walk me through. So like, how can I put this stuff together?
So basically, this person was born and he has a risk factor of polycystic kidney disease, which increase your risk of having Berry aneurysm. And on top of that, he has uncontrolled hypertension. And you see that with the lacuna infarcts. And another thing is with hypertension, you have it can cause the increased pressure cause in the brain and cause the weakened vessels, as well as polycystic kidney disease attributes to it, which leads to hemorrhage and aneurysm in the brain. And because of the spread of blood in the brain and the pressure on the brain leads the patient to be unconscious and unresponsive.
That was fantastic. That was great. I mean, so we'll see how we may have to refine that, but that was exactly what I wanted you guys to get out of the first few sentences. So polycystic kidney disease, honestly, the connection was polycystic kidney disease leads to hypertension, right? So the polycystic kidney disease tells you why at the age of 43, he already had 2 prior lacuna infarcts, right? Because otherwise, I mean, how are you going to have such bad blood pressure at the age of 43 that you're going to have lacuna infarcts? It'd be very unlikely. So he comes by it genetically because he has polycystic kidney disease, develops really bad blood pressure, which he can't control because he's got polycystic kidney disease, and then develops these lacuna infarcts, which again tells you just how bad his hypertension is. It also puts him at risk of developing aneurysms, which can rupture leading to blood in the brain leading to higher intracranial pressure leading to smushing of brain and unconsciousness. Right? So in the first 2 sentences, you can figure out just about everything you need to know. So if you thought when you read these first 2 sentences, like most of you probably did, oh, I don't have enough information, I'm just going to keep reading, you're wrong. So there's a ton of information that you guys can gain. The way that you do that is to continually cycle through different stories and say okay, well, would this make sense? Would this make sense? Would this make sense? So David was saying, maybe there's a rupture of an aneurysm that leads to decrease in blood flow to a part of the brain. That'd be unlikely, right? Ischemia to part of the brain is unlikely to lead to unconsciousness, right? That would lead to stroke, but it wouldn't really lead to unconsciousness. You have to explain how could he present in coma, right? Because this is essentially coma, right? Unresponsive unconsciousness is by definition a coma. So he's presenting comatose. So a stroke is not enough to give you coma, right? Does that make sense? This is hard. This is why I think neuro is such a challenging one, because there is I think a lot of us sort of lack the fundamental sort of knowledge to go through it, but B, there are so many different scenarios you have to cycle through that you have to know how they all fit together. So that was great. Well done, Stephanie. Sharon, so he has no known drug, alcohol, or tobacco use. So why are they telling us this?
So that's probably indicating that when we go back to the first sentence, it's ruling out that obviously his unconsciousness is not because of drugs, alcohol, or tobacco.
Yeah, perfect. Yeah,
Right?
It's unlikely to be intoxication, right?
Yeah, so they can just
Yeah, exactly. Yeah, love it. Patricia, his temperature is 37.2, heart rate is 48 a minute, blood pressure is 172/96, and respiratory rate is 6 per minute with labored respiration.
So his temperature is normal, heart rate is low. I can think about Cushing, about intracranial hypertension. Yes.
Oh, I could kiss you right now. Yeah, keep going.
Yeah. Blood pressure is 107/96 is high, and respiration rate is 6 is low. With labored respiration, this patient is tachypneic with toxic.
So again, the question I'm going to ask you is what? What am I going to ask you right now, Patricia?
This patient has signs of intracranial hypertension.
Good.
And
I'm going to ask you, what does this mean in context? Right? Because that's the question I always ask after every sentence.
cerebral edema or hemorrhage.
Okay. So again, again, you have to be paying attention to the first several sentences, right?
Mhm.
So what are we thinking from the first several sentences?
In the first sentence.
Huh?
Sorry, I don't understand the
So
question.
you said maybe cerebral edema, maybe hemorrhage. Well, there's one, like, which of those things would make the most sense based on the first three sentences?
Yeah, because the heart rate is incompatible with the blood pressure.
Wait, what?
The blood pressure is high
Yep.
and my heart rate is low.
Uh-huh.
So that didn't match.
Well, what do you mean they don't match?
It's usually seen in Cushing signs in intracranial hypertension.
Okay. Right. But I'm asking you, why is there intracranial hypertension?
Why?
Yeah.
Probably because bleeding, because I have two risk to anterior cerebral communicating aneurysm because the polycystic kidney disease plus lacunar infarct related with hypertension with bridging veins lesion. Yes.
Yeah, exactly. Yeah, that's perfect. That's great. So does everyone follow what that means? So like Cushing's triad. What is Cushing's triad? Do you guys know what that means? Hypertension, bradycardia, irregular breathing. You guys have heard of this?
Yes.
So yeah, so it's what happens in intracranial hypertension. So good. So the patient has a GCS of 5 and is immediately intubated and started on mechanical ventilation. So Parag, can you make sense of that?
So he's a Glasgow Coma scale of 5, being that he's unresponsive. Basically, it's anything under 7 out of 15 causes problems. But he's intubated because his respirations are at only 6, and I think that's really low compared. So you want to make sure that he's actually breathing properly.
Yeah. So he's actually intubated most likely for his mental status. Respiratory rate's probably not great either, but yeah, it's almost assuredly because of his mental status. So the reason being, right, if you vomited right now because you got food poisoning or something, and it started to go into your lungs, your vocal cords would close. You'd start coughing. So in other words, you would have airway reflexes that would protect your lungs from that vomit. If you have a depressed consciousness, right, either because of intoxication, because of anesthesia, because of intracranial hypertension, you will not have those airway reflexes. So we'll talk about this later. I don't want to get too far afield, but he's actually intubated because of his GCS of 5. Anything below 8 or anything 8 or below, you would intubate because they don't have the ability to protect their lungs.
Well,
what's up?
Quick question though. So, is it possible to go over the Cushing reflex after the question?
Yes, if we have time. There will be time. We probably won't be able to get through more than just the question for this session, but certainly in another session we can talk about it.
Okay.
Don't let me forget though.
Won't do.
Josh, walk me through. The right pupil is 9 millimeters and unresponsive to light, while the left pupil is 4 millimeters and constricts in response to light. So what's that telling us, Josh? And again, how can we make sense of this in context?
There is the stroke or the bleeding is causing some type of lesion or it's causing like nerve damage. But I'm not, on top of my head, I'm not sure what pupil, like the nerve.
Okay. David, walk me through. What does this mean? What's the significance of this?
Okay. So basically they're telling you that the right pupil is unresponsive to light. So basically whenever you shine a light into the eye, it should constrict. And since they're telling you that, they're telling you there's a cranial nerve, probably damage to the cranial nerve 3, or cranial nerve 2. But most likely, the only thing I don't like about the sentence is that I'd like to see if there is like how the constriction is in the other eye when you shine light to the opposite eye, if that made any sense. But putting that beside, there is a cranial nerve issue.
Yeah. But again, I mean, like, again, in context, if the only thing that they showed you was right pupil is 9 millimeters and unresponsive child, then yeah, I would look at the other eye. But again, consider the context,
Okay.
right?
In
Like, what do you
in
think
this-
is going on?
Yeah. So in this context, I think there's some kind of, I'm gonna be more specific, but there's some kind of issue with cranial nerve 3. I'm just gonna go out there and say it. Cranial nerve 3, and specifically the right cranial nerve 3 compared to the left. And I think that's because there's either because there's decreased blood flow or because there's brainstem herniation because of increased intracranial pressure that's causing the dysfunction.
Too wishy-washy. You got, I mean, like, you got to put your nickel down because that's not gonna get you the answer to this question.
Yeah. Okay. So you know what? If I had to go with it, I'm gonna go, since the pathophysiology makes more sense that way. I'm gonna say there was an aneurysm. You had a rupture of the aneurysm, which caused increased intracranial pressure. The increased intracranial pressure caused basically caused brainstem. I'm trying to decide whether it's because of a lack of flow, because the thing that's bothering me is the left one's okay, but the right one isn't. And if you're thinking increased intracranial pressure throughout and a brainstem herniation, then I would say that I would think bilateral if that was the case, if there was a brainstem herniation. So I'm thinking more like there was hemorrhage, and because of the hemorrhage, you have complete brainstem dysfunction. That made any sense?
It's a little wishy-washy. Okay. That's okay. So the deep tendon reflexes, okay, so Jolan, deep tendon reflexes are 4+ in the left upper and lower extremities and 2+ in the right upper and lower extremities. So how can it make sense of that, Jolan, in context?
So deep tendon reflexes are hyporeactive. So then I'm still thinking it's a upper motor neuron lesion. And if it's only on one side, so only on the right side of the extremities, then that would be contralateral to the lesion. So it's a left-sided lesion.
Wait, hold on. They're 4+ in the left extremities and they're 2+ in the right extremities.
Oh, I'm sorry. It's the opposite. It's the 4+ is actually the pathological side.
Correct. Good.
Right.
Okay. So again, what does this mean in context?
So if you put it together with the right pupil, you have the right pupil is unresponsive. So that would be ipsilateral to the lesion. And then the left upper and lower extremities being pathological would be contralateral. So then that is consistent with a right upper motor neuron lesion.
So again, in context. So one of the things why neuro is so hard is because you have to put all these things together.
Yeah. Sorry, I'm going there. So if you put it back to the fact that this guy has polycystic kidney disease, which is a risk factor for the uncontrolled hypertension, which then led to the multiple infarcts, then he ended up having a lot of bleeding, and that bleeding caused brain damage and swelling and edema, which then compressed the cranial nerve 3, and then also compressed either the compression or like the MCA or the ACA were compressed or ruptured in that region. So then it led to, actually, I'm sorry, I don't think it's the MCA or the ACA because we're still talking about brainstem. So we're thinking cranial nerve 3, and cranial nerve 3 would be above the pons, so most likely in like the medulla part of the brainstem.
Yeah. So the idea, okay. So who wants to tell me what they think the answer is to this? We're running out of time, so I don't want to. Let's skip to the fun stuff. So Joel, what do you think the answer is? B, C, D, E, or F?
Well, we can rule out, I don't think it's A or B or C or E. So I think I can cross those out. Vertebral artery, I know is on sort of the pons. You have like the basilar artery and then you have the vertebral artery right next to it. So I don't think it would be F either. So I would want to go with, gosh, but I'm not really sure. I feel like I can rule all the other ones out, but I don't know how to rule in D. So I'm thinking it's D just by elimination process because I forget sort of.
Okay,
What-
Stephanie, what do you think? A, B, C, D, E, or F?
I think D.
Okay, why?
Those would be more like focal, like, well, because we know this person's definitely bleeding out, and basal ganglia is one of the areas that the hypertension also hits too, and I think there's like a herniation too. I just want to choose thrombosis because I think there'd be more distinct.
Okay, perfect. So give me the pathophysiologic chronology. So he is born
Mhm.
polycystic kidney disease. What happens next?
So he was born with polycystic kidney disease, which gives him the risk factor for uncontrolled hypertension and for increased risk of aneurysm. So then the hypertension persisted, and he gets to lacunar infarcts, which led to aneurysm and hemorrhage into brain, which caused the increase of pressure in the brain, which also could cause a herniation, leading to his like physical finding and leading to be like unconscious, unresponsive, and all his hyperreflexia on the right side of the brain. So it's on the right side of the brain, definitely. And then I don't know if I did that right.
Yeah, perfect. No, that's great. So if I had to write it out, I would say, so he's born with PKD, probably autosomal dominant PKD, which leads to uncontrolled hypertension, which ultimately leads to lacunar infarcts / Charcot-Bouchard aneurysm, which leads to rupture, right, in basal ganglia, which leads to hemorrhage, which leads to ICP up, which is going to lead to basically Cushing's triad / early signs of herniation. So you're going to get cranial nerve speedy compression on the right side. Plus, you would get, you can get corticospinal compression, which is going to lead to blown pupil on the right, as well as upper motor neuron findings on contralateral side. Does that make sense?
Alec, I had one question for you.
Sure.
This is why I'm kind of hesitant, or I was hesitant saying it was a brainstem herniation, is because is it not true that if you do have a brainstem herniation that I never realized that it could cause unilateral symptoms.
Yeah.
I
why
thought
not?
usually-
So if you had really high pressure on one side of your brain, what do you think would happen? Do you think the other side's gonna so certainly eventually both sides could herniate out, but one side is gonna be one side before the other.
Okay, I see. Yeah. And then one other question, I guess it's a follow-up on that, is if you do have a hemorrhage, could you not get let's say it is a specific artery that does end up having a ruptured aneurysm and you do have a hemorrhage, won't that specific part of the brain stem, or even brain for that fact, couldn't it have decreased blood flow just because now you have a rupture?
Presumably could, yeah. But again, that you don't have to invoke that in order to
Okay.
explain any of the symptoms.
Okay, I got you.
Because the symptoms are all symptoms of high intracranial pressure.
Got you. Okay.
Yeah. If you disrupted the blood flow, dude, yeah, certainly. I would expect that you would have ischemic symptoms, but none of those symptoms are ischemic symptoms.
Okay, I see. Okay.
That makes sense.
Yeah.
Because if you get ischemia to a particular part of the brain, that's a stroke. That's not unconsciousness.
Got you.
But you don't get a coma from having like an MCA stroke, unless there's some sort of like intracranial hypertension.
Okay.
Right.
Cool. Makes sense.
All right,
Okay,
guys, thank you very, very much. Well done. This was really challenging. But again, this is what it is that I want you guys all to aim for when you're studying in general, but specifically for neuro.
If neuro finally clicked, the next video shows you how to apply this same thinking to every subject. You'll learn the framework that stops you from missing questions that you already know. Click here to watch how to virtually guarantee a 260 plus on your Step 2 and see how some students went from failing to getting some of the highest scores.